Uh, we are all aware that the sleep cycle changes while the patient is in the ICU. Probably it does change quite a bit even in the high dependency on semi-ICU areas, and to some extent even in the other wards of the hospital while the patient is in the hospital. Various reasons. The reasons are very clear. Excuse me. Are we from here? Yes.
Yeah.
Okay. So, patients in the ICU, when they were asked later on, and at the time of discharge or subsequently in the follow-ups, they usually said that the quality of their sleep was very poor while they were in the ICU. Well, understandably so. But then, people try to look at the underlying causes. It was found that it is not just the ICU environment which we tend to blame, but primarily what disease the patient comes with. If the patient is having a surgical thing, it's a recent surgery, or coming down from the OT and then he is on sedatives, on morphine, and maybe even on vasopressors, and the patient is on is also having pain. So how often are you measuring the pain score? And then patient may also be having nausea, vomiting. There are lots of reasons that would be directly related to the illness of the patient. Of course, besides that, the patient has his psychological aspects going. He's in the ICU. He's afraid of the ICU. When he was not in the ICU, he knew that the sick patient would go to the ICU. And whether he is going to survive, he's not going to survive. And he also knows that their mortality is happening around. So they also know that there was this patient in that bed and he's no more, the bed is empty. That means something has happened. So there's a lot of psychosomatic element and agitation going on in their minds, besides a whole lot of things that they keep thinking about their future, if they are in a position to think. So these are the aspects which are directly related to their disease. But apart from that, it is the environment that we as doctors, physicians, administrators create that in the ICU, or the ICU itself creates for itself, where there are lots of commotion going on in the unit all the time. And all the commotion is basically to help the patients anyway, no question about that. But then, a few other things also, which can to some extent be minimized. What it leads to, whenever patients are in a noisy environment, they would have recurrent arousals. Now, that arousal mechanism varies from patient to patient a lot. And some patients would be far more sensitive to even very low decibel sounds, while others will not be. So, the arousal leading to a bit of wakefulness, and then the patient going back into sleep. Now, most of these patients tend to stay in stage 1 sleep. Those of you who don't do sleep medicine, I would just briefly tell you that 1, 2, 3, 4, and rapid eye movement sleep, in which we dream. So, stage 1 and 2 are lighter sleeps. But stage 2 is a bona fide sleep. Stage 3 and 4 are the deepest phases of sleep. Now, the newer nomenclature, they combine 3 and 4. They say, okay, fine, there's no need to segregate them. If somebody has slow wave sleep pattern, then it could be stage 3 or 4, whatever. So the point is, you need a very high decibel sound to arouse the patient from stage 3 or 4. This is the sleep which is really restorative for us. Now, if we spend a couple of hours in our slow wave sleep, that is good enough to keep us fresh. But it doesn't happen. Most of our sleep tends to be in stage 2, a bit in stage 1, and a bit and sometimes significantly in stage 3 and 4. And the REM sleep comes in between every hour and a half, usually. Not always. In fact, it varies so much in different individuals. So, if the patient is going into arousals, stage 1, arousal, stage 2, arousal, and not going into 3 and 4, he would be dopey and drowsy in the daytime also. So even if he has apparently slept for 8 or 10 hours, it will not be restorative sleep in his case. So sleep deprivation is a very important issue, and it also in sleep